Hey everyone, good to see you all. We're letting a few more people come in. And Kat's getting the stage set for us.
Okay, let me know if you could see it and if it's clear.
Yeah, drop that into the question box and let us know.
Can you make it a little bit bigger, Kat? I think people should be able to see it now. Okay, that's good. I think that's good. I can see it. I'm not sure about others, but
Cool. We have a couple of our guest speakers still rolling in, so thank you for being here at 2 o'clock. And we have a few more folks coming to join us as well.
It's always a surprise, right? Because we don't always give heads up about what's coming. So you have to be here to know.
Yeah.
You have to be here to know what's coming.
hey, Delight and Kat, am I looking for a certain name to move over?
Well,
as a participant?
We are expecting Bobby.
Okay, do we know if
Yeah.
I don't see him as signed in? Is he with someone else?
He's set as a panelist to come in like Molly. So
Okay.
I think if he follows the link, he'll be joining us shortly. Sometimes there's a little bit of lag time in the office. I know Kara's in the office right now too. So just trying to get that like go-to meeting to launch can actually take a moment when you're trying to activate it.
Okay. Yeah, they're coming in. If we could give them just a little bit more time.
We could talk about the weather, guys, just because it's I'm just gonna say that August has been beautiful. At least
the first day of it, right?
Some of it has been.
At least in the, Anchorage Valley.
It's August 1st.
Yeah, I was gonna say. All 14 hours of August 1st have been beautiful in South Central Alaska.
So far.
Yay.
We're overdue. Okay, so we have the wrong agenda in the handouts. That's okay.
This is the last one, and it's giving me an error when I upload this one, so I'm gonna have to save it as Adobe and try it again.
Okay.
And do it again. For some reason, it's giving me an error.
I've had that happen as well when it's live like this. Yeah. Sometimes that can happen.
Nope. Not to make everybody dizzy with my screen. So. Oh, now it's working. So yeah, it can't be in Word.
Probably doesn't accept the Word file.
Yeah.
It's in. I see it. Thanks,
Yep.
Kat.
I think we could get started. It's already 2 after. So I could get us started. So the first announcement we have, welcome to our August 1st, right? We're starting August off with InfoShare. To our August Care Connection InfoShare. And let me just double check our attendees. I don't see Bobby, but that's okay. So we do have we were hoping he was going to be able to attend, but we have a new Chief of Quality. I don't know, guys, can you still see my screen?
Yeah.
Okay.
And if he pops in, I'll monitor for him. And when he pops in, I can do a segue to, bring him into the fold, so to speak, of this experience.
So Bobby Nave is our new Chief of Quality, and he started yesterday. And some of you may be familiar with Bobby because he is a former SDS employee who then went to residential licensing, and now he's back, and we're super excited to have him. So if he doesn't pop into our InfoShare today, we'll make sure that he pops in the next InfoShare we have. I don't know if you guys wanted to add anything. But...
No, I think you covered it. We can move on to our next presenter.
And then we have Molly, and I see Molly's here. So Molly is gonna do kind of a quick talk about hospital discharges. And I think we could allow probably 20 minutes or so for Molly to talk, and then for some questions. So you guys, as you're listening to Molly, if you could come up with questions, maybe put them in the chat, and we'll try to read them off. If we can't get through all of them, we'll make sure Molly has them afterwards, and then we could issue an FAQ or follow up with you directly afterwards. But Molly, if you want to make sure your mic's working and really quickly just test, and you could take it away. I think we're ready for you.
All right, can you hear me okay?
Yeah.
We're good.
All right, well, I am here with Paula. There we are, Paula. Paula Ray, another one of our nurses, helps me to oversee all of our assessments, incoming assessments, and processes all of our facility request assessments. So we wanted to talk a little bit about hospital discharges. We also refer to them as facility assessments, or assessments in hospitals or nursing homes, and they're looking to discharge and looking to get services, preferably upon discharge, although that isn't always timely like that. So generally when they come in, once an application is processed complete by the apps team, it will get assigned to us, and we will review the application looking specifically for information about the hospitalization or the admission to the facility. And most importantly, we're looking at the discharge plan, or what the discharge summary or discharge disposition might tell us. So we're not so much focused, while it is important information, our focus for the assessment is looking at what the post discharge needs, or what the needs are going to be after someone is discharged. That's where we look to identify what, specific services they might require. For example, home health services, physical, occupational, speech therapy, wound care, things of that sort. And so we're very interested in what that discharge plan is going to be. That type of information also helps us make a level of care determination. So we are looking specifically for that type of information. While we know there may not always be a firm discharge date, there might be. It sometimes varies. So we look for maybe an anticipated discharge date. Generally, what we're looking for is whether someone is ready for the discharge. Sometimes we get information that the person is ready, but when we get into the actual assessment, we find out that the person isn't ready for discharge. They are still requiring acute care, whether that's by treatment or what have you. And so we are not able to make a level of care determination. It's hard for us to figure out what the post-discharge needs are going to be. And because of that, we are not able to make a level of care determination. So we've seen an increase lately of assessments being requested where we find the person isn't quite ready for discharge. They still have their central lines in place. They still have catheters in place that the disposition doesn't present to be that the person would discharge with that catheter in place or that line in place. Or so because we had already approved the assessment was completed. It resulted, some of them resulted in denials, level of care denials. And so we held on to those assessments while continuing to follow up with the hospitals to see when and if the person was ready for discharge. Some ended up admitting to a nursing home. Some ended up being approved for level of care, and some of them are still in the hospital because they're not ready for discharges. So you may see a letter or a notice that we're closing out the assessment, and it's for those types of reasons. There is no discharge insight, you know, and our window really is the 30 days. We can't give it too much more time than that. And once we realize we're gonna end up being outside of our required timeframes, then we will move to make a decision. And then of course, you know, we encourage reapplication if and when the person is ready for discharge. So any other thoughts about that, Paula?
No, we've also had the people where they're really approved and then they hang on to them and they don't even let them go. So, and we shouldn't even be doing an assessment. We've had those too, so.
And sometimes it's hard to kind of figure out what the actual discharge plan might be. Situations come and go, things change. And so we understand that. And it's not so much an issue when we see level of care, but we definitely don't want to issue a denial notice when we don't have all of the information we may need in order to make that level of care determination. We would rather not deny someone's level of care right up front. And so we've kind of been monitoring these assessments, and some shake out okay and some don't. So just kind of, you know, having that conversation with the person, the individual, the applicant, and, you know, maybe the discharging nurse or social worker, and getting a good feel for that discharge plan and when, you know, discharge would be in sight if and when that is appropriate, and, you know, what timing we should be considering. So, Kat, was there anything else you wanted us to kind of talk about? Those were the main points we wanted to just make sure we.
I think you covered it all. Sorry, I'm like having issues with the computer.
There we go.
I'm just gonna take a look at the questions real quick, and Delight, feel free to jump in if you see any questions that are.
And I see Bobby's joined us, so.
And yes, we could welcome Bobby. We kind of did a quick intro for you, Bobby, but if you want to introduce yourself.
Yeah, sorry I'm late, everybody. I was in another meeting. You know how the like kind of business goes. I am Bobby Nave. I am the new Chief of Quality for Senior Disability Services. I think most of you that are seeing my name or know me from interactions I've been with. Prior to this, I was residential licensing for a year as a program manager over there. And then prior to that, I was here at SDS as the program manager for central intake. I've been with the state for about 18 years as of last March, either at Division of Juvenile Justice or residential licensing and healthcare services, or here at Senior Disability Services as central intake program manager and the new chief of quality. Filling big shoes in, you know, from Lynn going up to the deputy director, but looking forward to moving forward from here.
We're so glad that you took some time on this first day. Like, I know it's day 2, but we really appreciate being responsive. Literally yesterday, we cornered Bobby in the hall and we're like, hey, would you like to connect with our care coordinators? So, and he was down because he knows that you guys are an essential part of this process. So we're really looking forward to what you bring to the team in this new role, Bobby. Really appreciate it. I see a bunch, well, not a bunch of questions coming in, but a few that have come in for Molly and Paula. Bobby, you're welcome to stick around and hang out with us for as long as you wish before you have to leapfrog to some other meeting that I'm sure you have lined up. Kat, do you want to broach any of the questions that you see on here?
Oh, I did not get a chance to look at them, so feel free to do.
Oh, it's okay. I
have
guess
two
Molly.
questions. Do we want to do those
Yeah.
two or no?
I can just kind of like summarize the biggest struggle that we're kind of hearing from care coordinators is it's really hard to gauge where like the timing on this, from their standpoint. Do you have any recommendations on, what are some of the best ways that they can kind of connect in the timing to get that application in, but not too early, but they want those services in place? It just really can feel like a moving target because the client's care isn't stabilizing. Or it seems to stabilize and then deteriorates. Do you have any suggestions that could help them kind of approach that, or tips for approaching that?
Yeah, generally, whenever someone is admitted to the hospital, discharge planning starts upon admission, on the hospital's part, and just I think it really stems from that conversation with the discharge planner, or who I know the hospitals are encouraged to help the patients connect with ADRC, and that's where the connection to the care coordinator sometimes will start. It's that conversation with the person and the hospital discharge coordinator, whoever that might be, and getting a true understanding of what needs must be met in order for discharge to take place. So some of the cases we're seeing, the person still needed 2 to 3 procedures during the week to manage wounds. And so despite the documentation coming in stated the discharge disposition is continue inpatient care, social work continues to work on outpatient placement or options. So we see where there's a conversation happening about discharge for discharge. So yes, we understand it can be challenging to gauge the timing. That's why when we looked at the application and we were reviewing to see whether the person was ready, we took that to mean that while they're probably going through some, maybe last remaining procedures in the OR, the person was ready, but it didn't quite work out that way. The person continued to need, actually 5 weeks later, the person continued to need more OR time to manage wounds. And so we had to, unfortunately close out that application, but doesn't mean that, that's the be all end all for the person. We're just looking for when that updated information is going to be. So when we see an application come through, we're going to review the application and look to see whether we have information documented that speaks to the person being ready for discharge. Understanding that that might change the very next day, if not the very next hour, things can change. So we may proceed with an assessment. We just might not be able to get all the discharge information we need in order to finalize a level of care determination. Hope that helps.
So that does. I'm just hoping maybe to like, so what you're kind of saying is that, you know, when you're working with the discharge planner, they're producing a discharge plan like as soon as that client goes in, but a care coordinator is going to have to kind of track the trajectory there and be like, you know, there's several procedures down the line, or there is, you know, there's like surgeries and like recoveries, and it doesn't look like it's going to be happening tomorrow. But when you get close to that time, you can do all the prep for that application and prep for those pieces. And the closer you get to when that client stabilizes or appears to stabilize, to put it in, even though sometimes it might go back and forth, if the application does get closed out, you can reapply using the majority of the resources you've already collected, with probably the addition of like the additional documentation that's happened in between when you first applied and the significant changes that have happened that would indicate they're closer to discharge. That kind of summarize it?
Yeah, I would say the most important.
I like the storytelling though, because that's important.
Yeah, I would say the most important conversation there is with the hospital to speak to what needs must be met in order for the person to discharge. Meaning, if they're in there for the wound care and you know, they're now, you know, getting ready to close the wound up and, you know, should be ready for discharge, you know, the following week, you know, great. Compared to, well, we're still kind of tracking how this wound is healing, and an anticipated discharge date does not look viable or reasonable within the next 2 weeks, or within the, you know, I would kind of keep that check-in with the applicant or the legal representative, or even the hospital if I know that's going to be more work on the care coordinator to track, and they may not want the responsibility of that tracking. So I kind of see it falling on the applicant or the person to connect with the care coordinator when they see that is that we're within a fairly reasonable time frame for discharge.
Awesome. Thank you so much for taking time to talk with us today. This process is always a moving target. You know, it always is. And so I think the real gem of the story here is that it's really about communicating with the LTC and really kind of dialing in how ready are we to transition home, how stable are we to be able to receive home and community-based services, and then put in that application for that process. And I've experienced this as well. I've had people confused. You do assessments in the hospital, right? Like, because there's been confusion about that before. Assessments do happen in the hospital so that we can do those transitions straight from the hospital to ALH. But really it's one of those tricky processes. And we do have several other comments in the that we're tracking, and we really appreciate it. If we don't dig into it at this session, please know that your feedback really is valuable. So please don't hesitate to give us your perspective on different topics on it, or different views on this topic. We do appreciate that. So a really good question, like a point of, you know, like a contact question, who's the best person in the NFLOC unit to contact with questions when it's like a case-by-case discharge and you're just not sure what to do? My off-the-cuff answer is come to office hours, and then we can help you determine, you know, if it needs to go even further and we need to like contact Molly or Paula, or another team member. So don't hesitate to come to office hours or email Kat at Care Coordination Support if you just need a case consultation on what your next steps are.
And thank you, Molly and Paula, for coming and joining us today. I think it's a topic that's come up a lot recently.
Yes, yes. I think another question that had come up was when the person applied while they were still at home. And when we tried to schedule, we found out they were in the hospital. And so it got kicked over to the nursing unit from the assessment unit. And so there was some confusion about that. In order for a facility assessment to be approved, we do require discharge information from the hospital that speaks to some sort of a discharge plan or disposition or so. But like Delight said, absolutely, we are available. Shoot us an email or call us and we can help to staff any cases or questions. But yes, the highlight of it is communicating and making sure that we have all the pieces in place to finalize an assessment and an assessment outcome. So thank you for having us. We appreciate the time and opportunity to talk about these different things we're seeing. And as always, we're here for anything we can help with. So thank you.
Thanks, Molly. And if more questions come up before we wrap up today, we'll be sending them your guys' way for some.
Sure thing.
Thank you.
Absolutely.
So I hope I'm still sharing my screen because my computer keeps freezing. Okay, just making sure. I usually have good internet, so I don't know what's going on. So our next topic, and we have Kara here to talk to us about non-emergency medical transportation. Kara, if you're ready to take it away, that would be great. Thank
Sure.
you.
Can you hear me okay?
Yep.
Okay, great. So we've talked about NEMIT before, lots of times with this group. I will encourage you to check our YouTube channel for our last formal recorded NEMIT session that we had with training representative from, at the time, Conduent. Conduent has changed now to HMS Gainwell, but it's not different. And then recently we had a provider association meeting where there were lots of questions about transportation and sort of blended understanding of what that is and what it looks like. So we figured we would, share it with care coordinators. Some of you may have been in that meeting where we had Carrie Silvers, and Tony and other SDS people. Kat was there and Delight. So I think Delight was there too. But anyway, we can share the essential information about it. The questions had come from the provider community about medical escort, what it is and what it isn't. So basically, there are three, this is how we explained it. There are three different kinds of transportation and escort that Medicaid can potentially pay for. Care coordinators are not responsible to request medical transportation, by the way. You're not responsible to request NEMIT or medical transportation. And it seemed that the transportation and escort was a little confusing to our provider groups. Medical escort basically is someone who accompanies a patient to assist during medical transportation. We referred them to our Medicaid recipient handbook that Division of Healthcare Services puts out so that they could know that medical escort is requested by the medical provider along with the transportation or the travel for medical reasons. There is also programs that pay for transportation and escort if necessary through early periodic screening or other kinds of medical escorts. These are all around medical visits. Early periodic screening is around well child visits, and medical escort is around medically necessary transportation for medical procedures. Escort itself is not a separate service. It was coming at us as like hands-on help for a person to get on and off an exam table or to wait in a waiting area and things like that. It's not a separate service at all. It's tied directly with transportation in all cases. And then it's not separately paid, like the escort is not separately paid. If the escort happens to be somebody's personal care worker, that's fine. They're paid for personal care. Or if they're the group home staff, they're paid for their shift, but they're not, paid for the escort part. It literally just escort. Okay, so home and community-based waiver transportation is not used for medical appointments, and that's waiver transportation with an escort if necessary to access community locations, right? So that is in the support plan. We're all pretty much familiar with waiver-based transportation. When a person has personal care services, there is regulation that allows for help within approved limits to get to and from medical appointments, and this is under Personal Care Services Regulation Covered Services. A personal care services provider may bill for personal care services for a recipient if they score for the ADL of locomotion, if a PCA is necessary for them to walk, either A, between locations and the residence, or B, to and from a location in the residence to a vehicle used by the person to access a routine medical or dental appointment. So if a person scores to that level for locomotion, there'll be some time allotted, and they need escort, I should say. They need that help. There'll be some time allotted in their service level authorization for personal care services for that escort to and from a medical appointment. Going back to the non-emergency, the escort for well child visits for children 0 to 18 and 18 and older who have a functional limitation, Medicaid can pay for transportation and escort. What Medicaid stated, Carrie stated, was that for adults, the escort is an individual that the member and member's healthcare provider have determined to be a person who can meet the expectations of an escort during the travel event. So that would mean that they provide the help for that person to access the medical care. We don't really, the healthcare services doesn't regulate who the escort is. For a child, it's going to be a parent or a person the parent has entrusted the care of the child to. Escort benefits are not a service separate, so they're not compensated. The act of being an escort is not a covered service. Doesn't mean that a caregiver can't get reimbursed for services they perform as a caregiver when they're escorting somebody. It just means that the caregiver isn't being reimbursed for just being the escort. Escorts must be 18 years or older. They can be medically trained, but it is not required. Alaska Medicaid expects an approved escort to act in the best interest of the person, the recipient, the Alaskan, and be capable of assisting the Alaskan during the travel to and from all scheduled medical appointments. An individual may be denied to serve as an escort for a recipient if the individual has demonstrated behavior that's not in the best interest of the Alaskan, or if the escort cannot fulfill the expectations of being an escort. We did get a question about can DSPs ride with the person to a medical appointment as long as the transportation service isn't billing for medical transportation? Best answer to that is that it's up to the transportation provider. Check with the provider for their policy on extra riders. For the NEMIT and EPSDT programs, early periodic screening, taxis, vehicles for hire, and buses allow an additional person in the vehicle. Most wheelchair vans allow an additional person in the vehicle, but the Alaskan should verify prior to transport to make sure there is room for that. Let me check and see if we had questions in the meantime, just so I'm not going on here without addressing them. All right.
We did have some questions. One of them is, can we get access to the resources discussing this? Like, we know that it's kind of in the care coordination guide, but is it possible for that to be sent out with the CEH email?
Yeah, I'm going by notes from the meeting that we had. So yeah, sure, I'd be happy to share a copy of the notes.
That would be great. Yeah. I think that That's one of the requests. You might want to read some of them because there's a little bit of, kind of summing up, escort is inclusive in the service, right? Who
Uh-huh.
provides those, who are the providers of that service of
Okay.
both transportation and escort?
Any medical escort providers out there, forgive me if I'm asking late. Escort is not a separate service, so it needs to be somebody who can help the person. If it's a staff and they're providing, they're associated with that person providing services, then that's who it is. There isn't escort separately. The escort is not separately paid, but their spot on the provider's ride is. It is, I mean, technically, it's an open seat on the bus for them. The provider is not paid for the escort. Do we have a written document? Yep, I'll put that together for you. Escort can be anyone. So who is going to do it? That needs to be somebody who can function as an escort, somebody who can help that person during the travel event. It's not a separate service at all. And, we did have sort of the same kind of backdrop thought process here during the conversation too, is that, there, it really isn't, it doesn't answer everybody's needs. Okay. There isn't separate escort available. It needs to be somebody who can help that person, but it's not a separately paid person just to go on the ride with somebody. If they're already providing personal care, they can be paid during that time if that's what they're using their personal care for and it's in their plan. But it's not a separate service. It's usually a family member, a guardian, or somebody who knows that person. So let's see, what else? I'll be happy to put these together, and you can always, join us for our office hours or send us an email or something if you need clarification past this too. There was a question that came in about people needing additional assistance, like getting on or off an exam table, and that medical personnel can't or won't do it, or don't do it. They say they don't do it. The question said, we're aware that respite can be billed during medical appointments if needed. Is there a way that medical escort can be billed during medical appointments? If possible, what needs to be done to document it? So respite is available to people who have a primary unpaid provider and who have a home and community-based waiver. Respite is there to give the primary unpaid provider a break. If the primary unpaid would have otherwise brought or accompanied the person to a medical appointment, but a respite worker is doing it instead, respite is allowed. Respite is not requested for the purpose of providing transportation and assistance to medical appointments. There is a memo out there on our main website that it's a link to a memo that talks about this particular aspect of respite. Medical offices, especially those billing Medicare or Medicaid, are required to be accessible to their patients. They must provide a reasonable accommodation to help all their patients access medical care in an equitable way. This includes physical access and cognitive access to medical care. We do also have it goes to the same memo about respite, where medical providers are expected to provide access for all their patients. If a person's mobility needs for medical appointments can be met by an escort, by a PCS provider or another escort who isn't a provider, this is available to them. If a person's need to access the community with an escort through waiver transportation, then escort is available to that person. If a person's mobility needs for a medical appointment can be met by an escort during a medical ride requested through Medicaid by the medical provider, that is available to the person. If a patient is denied medical care due to the provider refusing to make reasonable accommodations to the patient, best suggestion we have is to make a grievance report to that provider. All providers who are billing Medicaid and Medicare they must have a grievance form or method for the people they serve to make a complaint to them. I would suggest they use the chain, go up the chain, make a grievance report, fill out a report to centralized reporting, see the CIR link about the matter, and potentially to the ADA compliance office. There is a compliance office that takes care of the need for all our state offices, and by extension, those who are collecting state money to provide services to be in compliance with the ADA. So that is, if we don't know about these cases and instances, then we're not able to provide any guidance or assistance to our providers who may be refusing. And so we did hear that people are refused and things like that. So we would recommend that it's reported because it's out of compliance with being a medical provider. And so that's what I have. That's the gist of it. I just thought it would be helpful for our group. Provider group did hear it. I'm looking for
I did
questions.
put the link in the chat. So not in the questions, but in the chat to all of you. I put a link to the SDS Director's Communication. And right now there are 3 memos that are kind of touching on the topic. They touch on respite and respite for escort and NEMIT. And so, you know, you have a lot of resources there to educate yourself further on the topic and explore what SDS has communicated. So that is in the chat for you.
There's some questions, Kara. Can you recap really quickly? What are the 3 different transportation types?
Sure.
It's
Fine.
a waiver, right? NEMIT, and what's the third one? What's the question?
It's 3 separate kinds that Medicaid is involved in for people who generally have, you know, long-term care, medical Medicaid. So, okay, medical escort to assist a patient during medical transportation. That is when the provider requests it, and an escort can come along and can help. And it's not a separately paid person. It's not the provider allows them to come with the person to provide escort. That is ordered by their medical provider. Home and community-based waiver transportation is not used for medical appointments at all. Okay, it's used for community access. A person goes to the community. If they need to bring, somebody needs to come with them, an escort is available. It is not a separately paid person unless they're also providing other services during that time. There are limitations there. I am not prepared to, you know, run down all the duplications. There's some written notes about duplications there. I do not have the time to provide, you know, every duplication. For example, rehabilitation. We don't do transportation with that because an escort would be on, you know, the escort is the topic here, right? It provides transportation to and from the community event, the community location, I should say. So there's that. There's a ton of different duplications that apply. So these are it's basic information. So there's waiver transportation. And then there's SDS related personal care services escort. That is allowed for medical appointments only if they score a certain, they have a certain score for the ADL of locomotion in their personal care services service level authorization for the ADL of locomotion, and they need help to walk between locations in their residence, which is what that means actually, or be to and from a location in their residence to a vehicle used by the person to access a routine medical or dental appointment. So that is the only type of escort that is going to be available through personal care. But there was a previous reg set that covered people conferring with the medical provider during the appointment. That is no longer the case. There's no conferring with the provider. There's no time during the medical appointment. The personal care assistant can help the person get there if they score, but it's not transportation. We're talking about escort. It's just escort, helping them to and from the vehicle to the appointment.
Can you maybe clarify, Kara, the service of escort is not like service of DAHAP, right? It's not like you get a provider for escort. It doesn't work the same way that necessarily other services do. Can you maybe explain?
Say it again.
There's some questions about that. Can you explain how Escort works and how it's different from other waiver services? It's not like they have. You don't have a escort provider. It's not something. There's no agencies that are certified that have escorts sitting around that you could call
No.
and get somebody, right? Can you maybe
That's true.
explain
Yeah,
a little
Escorts, right. Escort is not a separate paid service at all. There's no such thing as staff being paid to provide escort. Okay, if they're paid staff, then they are possibly doing PCA during that time. They are possibly providing residential supported living for somebody who's living in a group home, where we would also authorize transportation. Transportation goes together with escort. There's no such thing as escort without transportation. So the person has to be eligible for transportation. The transportation itself can't duplicate what's already happening with that person. So all of the home and community-based services, if they're going to get transportation, they're going to be not living in a group home. They'll be living on their own, in their own home. And then they are getting transportation to access a community activity. They need somebody to help them get to and from or ride along with. Then that is somebody that they provide. It's an escort, somebody who helps out like that. It's not a separately paid position. There is no such thing as an escort staff. Agencies aren't hiring people to be escorts. Transportation agencies are not hiring people to be escorts. It is not that. It's just a person that is able to help that person during that waiver ride or that very limited PCA. The rest of them are medical. So the medical provider orders the transportation. If the person needs an escort, then that medical provider will talk with the person about who that might be, the Alaskan about who that might be. And then they'll decide who's going to do it, and then they'll make the travel arrangements. The care coordinator doesn't do that. The doctor does not provide the escort. Nobody provides it. The person tells them who's going to help them. Oh, my family member, my daughter, my son. Oh, I happen to have personal care, there's personal care time allotted during that time. It's usually not a paid person at all. Maybe the best way to think of it is if the person lives in a assisted living home and gets residential supported living, it could be a staff that the home provides if they're available. The doctor doesn't provide escort. They order it. They put it in they allow for it. They make a document that says the person needs an escort and can have an escort during this medical transportation. And that's usually their office will do it. It's not, literally the medical provider, but the medical office will do it. Okay.
Yeah, a little bit of questions about the interplay of when PCS is authorized for escort and how that works with NEMIT. There's some questions on how that kind of interplays. The big start is is PCS authorized? You'd have to have that set up first. And then the next piece of that is
they'd
having
have to score for locomotion.
Yep.
Right. And then they'd have to score for escort. And then the time that is shown on the service level authorization, you can go look at the blank form. You can see it's very limited time that would be authorized. And the PCA is providing the PCA service during that time. They're allowed to be providing escort service, but it's PCA. It's not a separate, I know it's hard to understand. It's hard to explain too, but it's not a separate thing. It's only with transportation, very limited time, based on the person's locomotion score. And it's not going to be above what's allotted in the SLA, a service level authorization. I'm glad that I generated so many questions. That's good to think about it. All right.
I think we may have some more questions for you. We only have 12 minutes left, and I think we need to get through just a couple of more reminders. And I think
Yeah,
we might
go
have
for
some
it.
more questions, but stay tuned for Kara's notes. So when the email comes out with, letting you know you attended,
Sure.
with the agenda, there'll be some notes. And if you go through those notes and still have questions, just email us.
And your 1 hour CEH.
Yeah. Just
So
email
that's
us
good.
and ask us, and then we'll be able to answer kind of more case specific questions, I think. So.
Hey, so for one of the questions, they said they are still confused on how to use the PCS part with the escort part. Should we have her come to office hours so it can be explained?
You're welcome to come to office hours for sure. You can definitely join us in office hours, and we can go through this and maybe answer case specific for who you're thinking about. Always welcome.
So we have 10 minutes left. I think we have a couple of just reminders. We are working on FAQs and training, and I don't know if Delight or Carrie, you guys want to talk about it, about the flexibilities that are ending and then the flexibilities that are permanent, right? Starting November 11th or ending November 11th, I guess depends how you want to look at it. If you guys want to do a quick recap of what you guys are working on or what we've been all working on. Or a preview, or not, just keep us in suspense.
Delight, do you want to go or do you want me to go?
You can start and I'll round it out with what's coming.
Okay, so the flexibility, we have FAQs coming out, first of all. So there'll be FAQs that will be very comprehensive. We had to work with a lot of teams to make sure people are understanding what is going on. For care coordination, we had new regs come in that were not enforced and will not be applied, I should say. Everything's enforced, but they aren't applied until after November 11th, 2023. So that is 6 months after the declared end of the public health emergency declared by CMS. Okay. So on November 12th, the new reg sets will be applied. So we have changes that have to do with care coordination. I'll focus on those right now. But anyway, we're going to have FAQs come out, and then we'll have trainings available, and they could take the form of just informational videos. They could take the form of trainings that or sort of like get involved in some of the trainings that we have in our learning management system. They could be included there. And it depends on the depth of the topic. We have comprehensive CFC training coming. And there's different, I know, it's great. There's different ways that these changes are still happening, and different ways that they'll embed themselves within our ongoing training, which is why I say, sometimes we'll say, go look at the video. Sometimes we'll say, read this FAQ. And sometimes we'll say, here's something brand new in our LMS that you need to go, you can do a training on for credit or something like that. For care coordination, we have a face-to-face visit required once every 6 months. And we have monthly visits with the person, and it depends on the waiver type as well, and CFC. That can be done by a virtual connection that must have a video component. All right. So if we're not, if we're visiting with a person virtually, then we're using a telehealth modality. And in our regulations, it states that it must have a video component. That makes sense. So that is going to be coming into effect or applied after November 11th, starting November 12th. So that's just one of the pieces that we'll be training out. Our FAQs are pretty comprehensive and ping off a lot of our different units. This is why it takes time, because we don't want to give information that ends up being taken back later, is changed and things like that. That's pretty difficult for people to follow. So wait for that. The nice part about waiting is that the information will come out closer to the actual implementation, and it'll be vetted information. So we have that change. We have new regulations for day habilitation that are new/old, newly applied regulations for day habilitation. It has to do with requesting above the limit, which is different than what we've been experiencing through the COVID era for request of day hab. That was a flexibility that's ending. We have a new regulation about providers who are legally responsible individuals providing personal care, which formerly was needing to end on November 11th, but can be extended or can be made permanent for legally responsible individuals providing personal care through CFC. Okay, so the person, if they have personal care through CFC, the legally responsible individual can continue to provide, not for any of the other services. So the flexibilities for LRIs providing day hab, regular PCS without CFC, and everything else will be done. So now you can see the level of complexity around it, or start to see it. What else? Do you want to jump into Light?
Yeah, I saw some questions in here that I think I just want to make sure are really clarified. And Kara, you did clarify it a couple of times, so I want to make sure it's really clear. We have regulations that were approved but never implemented. So public comment ended, and for lack of a better term, they just weren't used. So that's for day hab and employment services. We have COVID flexibilities made permanent, which is all of this dynamic around like the telemodalities, because I'm seeing in the questions, like, what's the difference between a telemodality and telehealth versus a telephone call? Very fair question, because it kind of got scrambled during COVID. And so now we're kind of tightening back up and making some of the tools permanent. So that's part of the information that's going to be coming out with the FAQs. The next kind of piece to know is, as Kara said, some of it's going to be courses. So for rehabilitation and employment services, we're going to be doing like foundational courses that incorporate it in these new regs. So you can expect to have like something to really work through as a care coordinator, learn more about these services, and for those provider types to get really experience with that information as well. But those are some of the big distinctions. I think that what you can do is, once these FAQs are released, you're always welcome to give us your follow-up questions if you don't think something's clear, and we can assess what's the best way to deliver that information to you. So if, like Kara said, if we need to do another info share, or if we need to just release some YouTube videos, like we'll just bust out some YouTube videos and Kat will email them to you. We'll take that based on your how you feel about the FAQs coming out, because they're coming out soon, because you have to start preparing your support plans for November very soon. And I'm sure you have lots of questions about how some of this is going to be implemented. So know that we know you need this information, and we're trying to make sure that it's as accurate as possible. Yeah, that's kind of my thoughts on it. Oh, and I am really excited. You guys, I'm so close to having a CFC training ready for you. We're on the home stretch. A lot of time's been invested in it by loads of people, and I'm really excited to have something for you guys to explore that topic in depth. But yeah, that's kind of my thoughts. Anything else, you guys?
No, lots of questions about when the FAQs will be available, and I'm gonna reach out to all the teams, and you guys, like you guys said, it's all the teams that kind of have been involved, and I'm gonna confirm some dates, but it's my understanding that it's gonna be the next couple of weeks or so. But I'll double check and make sure that we have it out as soon as it's ready. And we did see a draft today, so I think we're pretty close to getting it. And I know you guys are really anxious about knowing what's gonna be okay and what's not okay. And I think there's been a lot of kind of misinformation or maybe misunderstanding regarding some things out there. So I think those FAQs will clarify a lot of things. And we only have a minute left. So just as a quick reminder on our agenda, for the care coordination office hours, that are only on Thursdays now in the mornings, 8 to 9 a.m. But we also have the all provider office hours on Thursdays, 3 to 4. So you could come to either one if you need to. And then there's a link to the SDS YouTube channel in there, and also the training academy if you have not yet signed up. And how many users did we have last time, Kara? It was a
Like
big
850 or so. Yeah, that was a lot. So yeah.
And then we'll keep this recording open for a little bit more, maybe a couple more minutes, because I see there's more questions kind of coming in, and we'll want to make sure that our FAQs are as comprehensive as they can be. So if we need to add more questions or clarify some things, we will use your guys' questions to do that.
Yeah, and I'm seeing some feedback on people's preferred way to interface with training content. Please feel free to throw that in there. I mean, do you like going to the academy courses? Do you prefer info share style show and tells like we have right now, where it's like a webinar special topic? Maybe not an info share, but like, you know, a webinar. Maybe you like YouTube videos. What are things that help you learn this content? But you're free to go whenever you want. We're just here collecting your feedback, because your feedback is really important. Like, we really value it. I'm not shining it on. Like, seriously, it's really helpful for us to be able to address your questions and concerns, because that's how we can make sure that
And we
Alaskans are getting the supports
collect
they need.
the questions. You know, we could look back on those info shares, and we get a ton of emails with questions, and we do kind of collect them, and that's a part of how the FAQs are being developed. It's all the questions that have been coming in, and whether it's by email or calls or info shares or office hours, we've been kind of collecting all of those things and making them into FAQs. So we're not just kind of developing those in a vacuum. We are taking your feedback and questions and comments. But I think I'll give it 2 more minutes maybe for some more questions. Thanks for spending the first day of August with us, guys. And again, it's sunny in the Anchorage, you know, Matsu area, which has not been a lot of. So I'm enjoying it. It's been hard working today.
Thanks for all that you do. Come to office hours if you have questions or need a case consultation. We're always happy to answer questions in live time there.
Thank you, guys.